Hello friends, in this video I'll be talking about the management of a slightly harder grade of posterior polar cataract. Most of the times posterior polar cataract present in early stage where it can be managed with hydrodelineation and endonucleus prolapse. This was a case of grade 3 nucleus sclerosis posterior polar cataract. And when we did the lens OCT, it showed that it was a type 3 posterior polar cataract, which you can see that basically the posterior capsule is not easily seen. Possibly it is very thinned out or it might have been absent. So my plan of action in this case was to do the Patwardhan sideways sculpting technique, which is recommended for more than grade nucleus sclerosis grade 2. And I started with the capsulorhexis where my aim was to do a slightly oval kind of rhexis. Hydrodelineation was not attempted because it is a harder grade of cataract. A blunt dissection 360-degree with the iris spatula was done to make the epinucleus removal slightly easier. And then I started with the trenching. For the posterior polar cataract management, it is important to note that the chamber management is the most important part. There should not be overinflation of the chamber at any point of time and not even excessive shallowing. Here we do the phacoemulsification in slightly lower grades of IOP. Here I am using Centurion machine and the IOP being used is 40 millimeters. And my aim is to do a trench which is deeper in the periphery and thinner in the periphery, but the center should remain attached for as long as possible because possibly the center is attached to the posterior capsule and I want to retain it till the later stages. Now if you notice here, my technique of sideways sculpting had some limitations because of which it was not successful. The reasons for that we'll be discussing later in the surgery in the video. So my technique was now basically scrape with the Sangli and eat with the sculpt. It is not a very new technique, but basically it means that now I'm using the Sangli to scrape the nucleus and then eat it on a sculpt mode, which means that I'm using low vacuum. I'm not eating it on a quadrant mode so that there is no pull on the nucleus which is attached to the bag and I'm able to eat it under more controlled manner. Now this technique I have utilized because I was not able to do the sideways sculpting method. And this technique I have utilized in 2 or 3 cases of the similar nature, and it has been used by some of the trainee surgeons also who are not able to do the sideways sculpting method properly. So this technique is fairly predictable, but of course it requires a lot of patience because we have to be totally properly focused on the nucleus and then we have to keep on scraping the nucleus with using the Sangli. For the subincisional part, we can go in a more controlled manner with either from the side port, any of the side ports, and then continue the chipping without rotating the nucleus. So basically layer by layer, we are chipping away the nucleus and then eating it. Our aim is basically to make the nucleus a bowl and to be left with a epinucleus sheet, which we have to now manage. Now you know that this is now the second major part of the surgery. Here the main technique is the visco dissection technique. First we go from the main port and we have to dissect the epinucleus. It is important that we do not overinflate the chamber and we have to decompress in between. It might require multiple attempts, especially if the nucleus is slightly denser and if your CCC size is slightly smaller, which was there in this case. But it is important that you do not forget to decompress in between. So finally, I was successful for dissecting the epinucleus from the periphery. We have to go from both the side ports to ensure the 360-degree removal of the epinucleus. And then we can use visco dissection to float the epinucleus into the anterior chamber. The epinucleus removal can be done using the low IOP and the epinucleus mode, but we have to be sure that the epinucleus is free from the subincisional part, and we have to rotate it in front of the phacoprobe basically. At every point of time, we have to remember that we have to follow the principle of fluid visco exchange to maintain the chamber. Then the cortex removal was done using the bimanual technique, and this is the status after the cortex removal. If you notice in the center, possibly the center, the posterior capsule is either very thinned out or it is absent, but there is no vitreous. So I decided to put the lens in the back and then under control conditions, and then the visco removal was done using bimanual technique under low IOP. You can see that the lens is properly placed in the bag, and at the end also we avoid collapsing the chamber, and then we can hydrate the pockets under air bubble. So this was at the end of the case of this surgery. This was immediate post-op, slight edema, possibly because of the duration of the surgery. And this is posterior capsule picture at the end of 1 week. If we analyze why the sideways trenching did not work in this case. So the capsular axis is slightly smaller than 5 millimeters, and it caused some difficulty in managing the epinucleus. And of course, the inadequate trenching and separation of the periphery. If you notice, I was more cautious while stretching the epinucleus in the periphery, and if I had done that, then possibly with the vacuum I would have been able to remove the nucleus. Let us see the correct technique of sideways sculpting. So you can see that the trench plus sign has been made, and it is thin in the periphery, almost 70 to 80% depth, and the periphery has been properly separated. And then in vacuum, here we can use higher vacuum with lower IOP if we are using, and at least 1 or 2 pieces will be able to come. In one of the cases where the surgeon had stretched and separated the center, it led to the PCR in a similar case. And then the surgeon tried to do the sideways sculpting. So it is important that we create a plus sign first and then do the separation of the periphery, avoiding the separation of the center to as late as possible. So to summarize, for higher grades of cataract of posterior polar cataract, we can use the technique of Patwardhan sideways sculpting. For this, ensure that the trench is deep in the periphery but do not overstretch. If this technique fails, we can use the technique of scraping with Sangli and eating with lower vacuum sculpt technique. Aim is to create a bowl, and then we can manage the epinucleus by viscodissection. The main attribute while managing a hard cataract to remember is always patience. Thank you, and for more such videos, please subscribe.